And then, so we're going to talk about, this week's kind of odd because it sort of talks about gas exchange and pain sort of in the same week. Our focus today is going to be gas exchange. So talk to me about the kind of patients that you're seeing, could be at Clinica, could be in the hospital, that you're seeing that have an alteration in gas exchange. And like talk, I mean, the chat's fine, but if you could, if people could talk about their patients, that would be great. Anybody?
Yeah, I had a patient who had pain and they were having some complications with gas exchange. So it was a person who was homeless and was admitted because they didn't know they were diabetic and they were developing ulcerations on their body and really bad edema on their lower extremities. Mm-hmm. But while he was in the hospital, his O2 stat kept dropping to the low 80s.
Oh.
Yeah, and the nurse actually caught that, which was really cool to see her kind of get the ball rolling for his follow-up care. And then we got the respiratory therapist in, and then they had him on a CPAP machine.
Ah, okay. We're going to talk a little bit about that today, CPAP. What so what did he look like, or what were some of the way that the gas exchange, like the alteration, other than the saturation, obviously, but if it's in the low 80s, I'm thinking maybe there were other manifestations that you saw or that the nurse told you about?
Well, he did have poor perfusion. His breathing was, when he wasn't on the machine, it was labored and it was gasping.
Okay.
Weirdly enough, his he also kind of he seemed like he was a little narcoleptic. Like we'd be talking to him and then he'd just fall asleep, and then he'd come back and then he'd just fall asleep. So I wasn't sure if that was also related to maybe not receiving enough oxygen.
I don't know the answer to that question, but that is interesting.
Yeah, he was a very interesting patient.
Cool. Were you able, you guys learned focused respiratory yesterday, right?
Yeah.
So you probably weren't able to do a focused respiratory, or were you?
No, I just did the kind of the basic front back sides, and I didn't, it didn't sound too bad to me. Of course, I'm still learning, but I didn't hear any of the like rails or wheezing. So that was I was kind of expecting to hear something like that, but it sounded okay to me, but I'm still new.
Do you know, could you remember if when you listened that you actually heard the air move, the movement of air when he was breathing? You could hear the air move through inhalation and exhalation.
I believe I did. At this point, I'm not 100% sure, but I remember not being concerned.
Miss Sullinger, actually, I had the same patient.
Okay, can you hold on? Can you hold on for a second?
I had the same patient.
I understand that, but I have a couple more questions for Amanda, and then I'll come to you. Thank you, appreciate it. I lost my train of thought. Hold on. So respiratory. Did they figure out what the respiratory problems were coming from? Did they give it a medical diagnosis ever?
I don't believe so.
Oh,
I believe at that time, well, he had a lot of new diagnoses that they were working with. I know they were starting to educate him on treating his diabetes as well, kind of learning teaching him how to get started there. Okay. But the respiratory therapist was scheduled to come in at least once a day.
Oh, okay. Is there any questions or any assessment data that you didn't get yourself, or that you would have wanted to know, or questions that you would wanted to ask?
I guess I kind of wanted to just know more about his past medical history, because he was pretty vague. And he was pretty young. He was in his 40s, but he was morbidly obese as well. I believe his BMI was 60.
Whoa.
Yeah. So that could also be a big contributing factor.
Because it could be like sleep apnea or things that we're going to talk about sleep apnea, but yeah, interesting.
Yeah,
Cool.
definitely. And just not being rested because of his social situation too. He had a very stressful life.
Wow. Thank you. So now, Hugo, you said you had the same patient. Did you have the patient before Amanda or after Amanda?
I believe I had him before Amanda because I had him on Tuesday.
Oh, okay. So, so what can you tell us about, like, what things did you notice or see in regards to gas exchange?
I can tell you that it definitely was sleep apnea. I spoke with a respiratory therapist about it, and I experienced it myself. When I was talking to him, I experienced the same thing that Amanda experienced, where he would be talking to me and mid sentence, he would just fall asleep. This
Wow.
is like right in the middle of a thought, he would just fall asleep. And he would snore once or twice. And by the time he hit the second or third snore, he would stop breathing entirely, and it looked almost like agonal, like he was like his chest was like jumping trying to breathe. And then once he would catch his breath after about 10 seconds, or after I had to kind of arouse him a little bit,
Mm-hmm.
he would breathe really really, like he would inhale once really really big, and he
Yep.
would wake up and he would start talking to me again.
In the same thought, in the same sentence, or?
Sometimes in the same thought, sometimes he would just kind of wake up and like wait for me to ask another question, sort of thing. And
Gotcha.
so so yeah, so I definitely saw some sleep apnea. I talked to the respiratory therapist about it. um I asked him, I just asked him just straight up. I was like, hey bud, I was like, what's up with you, man? How come you're so tired? Why do you keep falling asleep when you're talking to me? And his response was, well, I just haven't gotten very much sleep lately. um, he sleeps in his car, so he sleeps sitting up, and so
Ah.
that's probably a very big contributor to. He has lymphedema in his left leg, much more so than his right, but um, he had a lot of pain in his left ankle. We're assuming because of the edema. At that point, we didn't understand why, but we're assuming because maybe the edema was starting to push his ankle out of place or something. Um, but he had the sleep apnea. Um, they ordered the CPAP machine for him, but after talking with Miss Sutliff, they weren't going to apply it until later on at night. And he was visibly, he was tired. He was trying to take a nap. His
Mm-hmm.
body was trying to make him take a nap, and so we ended up speaking with the RT, and the RT was okay with applying the CPAP during the day for a little
Yeah.
while, just to see if we can get him some rest. And so it seemed like everything we were trying to tell him about the diabetes, about the edema, about he was a smoker, he was homeless. His mother had thrown him out of the house, so he was living in a car now. Um,
Oh.
we tried to get a social worker in to talk to him. There's a lot of stuff that we tried to help him with, but everything that we were doing, he just wasn't really paying attention with. And so and so so yeah, so we tried to get the RT to put the CPAP on him during the day, to see if we can get him a little bit of rest, and see if by getting a little bit more oxygenation, we could potentially raise his alertness and his level of consciousness.
Yeah. Wow, that's really interesting, guys. Thank you for sharing. How were his breath sounds when you listened?
He had diminished breath sounds on the left, I'm sorry, on the right, just a little tiny bit. Air was moving, but again, he was 183 kilograms. And so
Wow.
he was 40 years old. He was a really big guy. And so, I mean, being able to just hear through his, the amount of skin and muscle that he had on him was kind of tough. So I asked the question yesterday when we were doing when we were doing our respiratory focused assessment. How do we know the difference between diminished lung sounds because the lungs are not adequately, performing, or diminished lung sounds because we just can't hear them through the amount of muscle or adipose tissue or both that this particular patient has? And I ended up getting an answer from Ms. Clark, but like I
Which
said,
was,
which
which
was
was,
check it from the back. Was
Mhm.
usually it fixes itself, when you check the back, because the breast tends to have a lot more adipose tissue, and the back
Mhm.
usually doesn't. It's a little more clear
You
of a
can try and
shot,
go by the sides too.
and by the sides also. But I mean, he had a bunch of adipose tissue on the side as well. Like I said, he was just a really really big guy, and so they had to order one of the bariatric
Beds,
um, beds for him and
the beds,
everything.
yeah.
He's a big dude, um,
Wow.
so
Thank
yeah.
you for sharing. Appreciate that. As other people have patients with respiratory Alterations in gas exchange, oxygenation. What do they look like?
The first week I worked with a woman who had COPD.
Yay! Okay, sorry, no, boo. I mean, but yay. So what did it look like?
Well, she was a larger woman. I'm trying to remember her BMI. It was up there in the 50s, I think. She was kind of barrel shaped, I guess you would say.
Yes.
But I don't know if that was just because she was a larger person. It would have been hard for me to tell, and I didn't know to look at that time. So.
Do you know now?
Yeah, I know. I would guess that definitely has a part of it, because she definitely was a kind of a round shape, not just like
yes. And that is due to COPD. That is one of the hallmarks of chronic obstructive pulmonary disease, COPD. Yeah. Right. And so what did she look like when she was breathing, or how easy or difficult was it for her to breathe? What's her O2 stats?
They had her on oxygen. They had her on a mask at first, and then it switched over to a cannula, back to a mask. And she had been on a CPAP machine a BiPAP machine.
Okay.
And they had, so she kind of struggled with breathing a little bit.
Do you know what her O2 sat was? Her oxygen?
They were trying to keep it in like the 90s. I mean, when she would just take off her oxygen, you could see it dropping.
Right. And so that would be my question. Like, how low did it drop without the oxygen, and where was it with the oxygen, if you recall, or anybody else that had a patient with COPD?
With the oxygen, I think they got her up to around 94.
Oh, good. Okay.
To be honest.
Okay, no, that's okay. So when you have COPD, which we're not going to talk about today, but we're going to focus more on pneumonia. But because it's a chronic obstructive disease, the oxygen saturations, maybe if you're run 88% in without oxygen, like that's a normal oxygenation saturation for a patient with chronic obstructive pulmonary disease. And then you add the oxygen on, and sometimes you feel like, well, why is it only 94? It should be more than 94. We've got her on, I don't know, 2 liters, 4 liters.
They kept adjusting.
So they're going to adjust it. They're going to titrate it based on where they want her saturations to be. And we don't, if we can get them above 94, that's good. Above 92 is good. Yeah, perfect. Anybody else? Or I'm going to go ahead and start the PowerPoint. We have 2 PowerPoints today because we're kind of putting in, we're going to talk about pneumonia, which is our exemplar, but I want to go over the concept first, and then into more specific upper and lower airway differentiations, because those are the 2 objectives for today. So I want to make sure that I cover those with you, and then hopefully we should have some time for activities. So let me go ahead and share. And I keep forgetting to publish the modules. So communicate with us, with me, with Ms. Clark, if there's nothing showing in the modules, because I am classic for forgetting to publish the module. Right? Like, let us, if there's links and things that aren't working, right? Like, ask us, let us know, because we may not know, obviously, that it's not working. What do you see on your screen?
Concept 19.
Concept 19. All right, so we can talk about gas exchange with a little infection thrown in there. Hopefully there we go. So we're going to, this is the concept part, the get-ins part. So we're going to talk about gas exchange and infection, and look at risk factors, and really recognize when an individual has compromised gas exchange, potentially with infection, but I also want to focus on that. And the examples that you gave me tell me that you're recognizing that, right? You can tell if there's a barrel chest, if their oxygen saturation, is lower, if they have sleep apnea, if they're falling asleep. Those are all things that you know, that tell you that there's compromised gas exchange. And you notice the one patient was smoking, was obese, the other patient was obese. So you're looking at some of those risk factors as well. So, so that's really great. So when you talk about gas exchange, related concepts, we've talked about nutrition already, right? And so how does gas exchange affect nutrition or vice versa?
Like people don't eat when they have some of these breathing conditions?
Potentially.
That would affect nutrition.
It would. Mm-hmm. That's a good example. And then if you have poor gas exchange, it's difficult to move sometimes, right? And you get tired, there's your fatigue. Gas exchange and perfusion go hand in hand. We're not going to deal with acid-base balance right now, but that's your pH, right? And where you are with acidosis and alkalosis. And then one of the key things is if somebody's oxygen starved, if you can't breathe, like your anxiety just goes, like your restlessness, anxiety, those are signs and symptoms that there's a gas exchange issue with that, because you feel like I can't breathe. Kind of like when you take a test. I don't know. So we're going to talk about gas exchange first. So when we talk about gas exchange, oxygen going to the cells, and then the carbon dioxide is being transported from the cells, right? Because you breathe in, and then when you breathe out, it's the carbon dioxide. We're getting rid of it. And so there's your scope, impaired gas exchange, and optimal gas exchange. And then you don't have to memorize this. It's just to show the process of gas exchange. It's right out of Giddens, and it shows you that oxygen piece and the carbon dioxide piece, right? So when you're, you know, breathing in and breathing out, it just sort of gives you a little breakdown of that process. And so when you have an impairment, when you have an alteration, that diffusion somehow becomes impaired, either the inhalation or the exhalation, something's affecting that. So it could be ventilation, the movement of the air through. It could be the capacity, right, to transport the gas. So if you have less blood cells or low hemoglobin or inadequate perfusion, right, then the blood and carrying the oxygen, it's not getting to the cells where it needs to be. And so things that you might see, fatigue, increase in heart and respiratory rates because you're trying to get oxygen in, to get the air in, to get to the cells. You can become acidotic, and then eventually ischemia, necrosis, and death. Right? If you can't move air, then life is not compatible with that. So we're trying to avoid that. So you have a couple different ways that can happen. You can have what's called hypoxia, right? So anything that's hypo is less than or greater than?
Less than.
Less than, right? Anything that has an A in front of it, anoxia, oxia being the suffix meaning oxygen, because it's the oxia part. And then A is an absence of, right? So anything with an A in front of it would be not the letter A, you know what I'm saying, but it's anoxic. So there's no oxygen. They're not moving. There's an absence of oxygen, right? So that whenever you see hypo, and then hyper would be an excess, right? So like hyperventilation, they're breathing really, really fast, right? And so what happens when you don't have the oxygen is you don't get the cells, the tissue don't get the oxygen, and they can't get rid of the carbon dioxide. And so then you end up with the cell death. And then we're going to briefly, so what happened is we were going to do gas exchange later in the semester, but then we realized that you were doing the focused respiratory this week. So we moved gas exchange up. So theoretically you would have had infection already. So I'm not gonna go into all the focus is not infection. It's just for the exemplar for pneumonia of how gas exchange and infection work together. But I did wanna give you a brief overview of infection just put the concepts together. So when you have microorganisms, like they're invading, they cause cell injury, and it's generally, you know, there's toxins, there's bacteria, that kind of thing. And so they invade the body. And it can be local cellular injury, right? And then what happens if there's too much local cell injury and it starts to branch out? Then what happens?
It can lead to a systemic injury, or
Systemic sepsis. You can, yep. And that is fourth semester. You talk about that in fourth semester. And so different causes, sources, you probably know this: bacteria, viral, fungal infections. You can also have parasites or protozoal infections. You know, where is it, right? Versus localized versus systemic. How long, you know, is it just an acute thing? Did it just happen? Or is it something that's more chronic? And then, you know, where did you get it? Did you get it in the hospital? Because unfortunately, there's a lot of hospital-acquired pneumonias or other types of infections that can happen. Or is it a primary infection, which is like the initial infection, versus a secondary infection, which would be because of related to another cause, like you're immunocompromised or something, and so you're at risk for more infection.
Ms. Sullinger, can I ask a quick question? Yesterday, I heard Mr. Espinas mention something about if a patient has a pneumonia, it was contracted at the hospital. And he said that, you know, and I mean, his thought in saying that was that insurances weren't going to pay for any kind of pneumonia treatment because it was almost always thought to be contracted at the hospital. And so I was just kind of wondering if you knew about that, or you could speak to that, or.
I've not heard that. Mr. Espinas is in the hospital more than I am. I mean, a lot of pneumonias do happen often from after surgical procedures. You know, you get pneumonias because you're not moving. But like most of the people that I know that have pneumonia got it in the community, but in the community could be from because they were in the hospital as well.
Yeah.
But I can't really speak to that. I don't know any evidence. I'm not saying there isn't. I just haven't read any evidence.
Got it. Okay. Thank you.
Yeah. And then, so, you know, you try to overcome the infection, right? Because we're always trying to stay in homeostasis, right? Perfusion, gas exchange, always trying to stay at that level. So the rest of your body starts to compensate. And that can be a problem. And then when you're thinking of risk factors for infection, you know, anybody, obviously, apparently the president can even have infections, and the very young, poor, uninsured, homeless, or geographic areas, right, where infection is prevalent and they don't have methods and means to combat that, or do the preventative treatment, or do health promotion to combat that. And then when we look at infection, things that can contribute to infection, inflammation, right? Because a lot of times what happens is those white blood cells come to the rescue, and then you get this swelling. But then when you have infection, you're also looking at nutrition, right? How does nutrition, right? Going back to nutrition, how does nutrition play a part in infection or fighting infection?
Your body's immune response needs good nutrition in order to be able to fight that infection.
Mm-hmm. Right. And then, you know, the tissue integrity, depending if you have, you know, if you already have an entry portal, right? Like if you already have a cut, or if you have potentially a diabetic ulcer or something like that, that's going to lead to an infection. We'll talk immunity, we're going to talk about later. And then stress and coping, because what does stress and coping do to your immune system? Right? With the stress and coping. So you're more susceptible to infection. So some of the exemplars that they were talking about for in Giddens for infection, we're going to focus on pneumonia, but they just give you some other examples: conjunctivitis, otitis media, hepatitis, and HPV. And I think at Clinica, people are getting the vaccine for HPV. I thought somebody that got the HPV?
Yeah, I think my first week that I was there, I saw somebody get the injection.
Okay, so now we're going to move back. Now we've covered gas exchange and we've covered infection. Let me check my chat here. And so now we're going to look at risk factors for gas exchange. I'm going to focus more on gas exchange. We did have those couple slides that talked about infection, but we're going to move on with gas exchange. So age, right? The very young, the very old. Smoking, we've talked about, like, that affects everything, right? We had what, hypertension, and now gas exchange and perfusion gas exchange. If you have a chronic medical condition, like Greg was saying, COPD, cystic fibrosis, your immune system becomes compromised, heart failure. You also, if you have a reduced state of cognition or brain injury, sometimes that can put you at risk. And prolonged immobility, right? We're going to come to mobility, I think, next week, talk about that. And so hopefully you're starting to see where the concepts kind of are interrelating or like overlapping and come together. And then you get this nice picture. And so how do you know when somebody has impaired compromised gas exchange? You guys were telling me that. That was great. So you're going to do your history, right? We talked about history taking. I think we did that more in 47. But you're going to look at their past medical history, family, their current meds, lifestyle, you know, all that kind of thing. And then when you do your exam, you're going to check your vital signs, right? Which you know how to do, including the oxygen saturation. And then you're going to do your focused respiratory assessment, right? And you're going to look first, you know, see what they're, so that was one of the things when I was looking at some of your basic assessments, is that you would listen to the lung sounds, but you wouldn't talk about the effort, right? Like what do they look like when they're breathing? Are they, you know, having a lot of, you know, effort? Is it like, you know, like that kind of thing to talk about. What does their thorax look like? Greg was telling us with the woman with the COPD, right? She was barrel chested because of the way that you breathe. It actually kind of reforms your chest. And you're looking at the, you know, are they cyanotic? What's their skin color? Those types of things. Different lab tests that you might see. ABGs, which are arterial blood gases, to see what the pH is. Complete blood count, that will tell you hemoglobin, white blood cells. Sputum, you guys are supposed to kind of take a look at the sputum collection part in ATI. That wasn't, I don't think, something to turn in. I don't think it was, but to look how to take a sputum sample. And then x-rays, CTs, MRIs, they can do VQ scans, which is ventilation perfusion. So how much do you perfuse when you ventilate? Those kind of things. And then there's also pulmonary function studies that look at your volumes of air that you inhale and exhale. And then endoscopy is where they'll put a tube with a light on it and kind of go down and look actually to see what the airways actually look like. Those are always kind of cool if you like that kind of thing. And so when we're talking about primary prevention, trying to prevent gas exchange problems, right? Infection control, hand washing, quit smoking, make sure you get immunized. What kind of immunizations would we be thinking about that had to do with gas exchange?
Prevnar,
Pneumovax.
Mm-hmm.
flu vaccine.
Flu, yes. I'm thinking of one more. Well, I guess kind of, yeah.
Is there a pneumonia vaccine as well?
Yeah, that's what they were saying, the Prevnar and Pneumovax. Yes, the pneumonia vaccine. I'm sorry, somebody said something I didn't hear.
Hep B?
Not Hep B. I was
Is
thinking,
it TB?
well, TB is one, but there's Hib. Yes, Hib. That's what I was thinking. Haemophilus B influenza. That's the one I was thinking of, because you can actually, if you get that type of the flu, the Haemophilus, it goes under flu, but it can actually lead to cardiac problems and other things down the line. So that's why it's important to get your immunizations. we'll talk about that, I think, at 47 later, because there's a whole debate on immunizations. And then looking at post-op complications, right? Because you're immobile, right? And so you want it, that's why we want people up and moving. And then somebody actually mentioned this, but can you think of any secondary screenings related to gas exchange?
X-rays, right?
You could, but that's not necessarily a screening. Like, it's not something that's done on a regular basis per se. I'm thinking of something that happens for healthcare professionals pretty much yearly.
TB.
Or
TB.
TB.
Right? You get you're screened for tuberculosis, right? And you have that questionnaire you have to fill out, and do you have night sweats and all that, and then you have to do the 1-step or the 2-step. That's a screening, right? So that's that would be related to gas exchange. Good, yay! There's actually not many screenings related to gas exchange. So x-rays are more diagnostic. It's not something that's necessarily done on a regular basis, whereas something like mammograms, which are a type of, x-ray, which are x-ray or scan rather, would be more of a screening, if that makes sense. There's also types of medications that can help, nutrition therapy, positioning. So like you said, the gentleman, your patient was sleeping in his car, so he was sitting up, right? So the head of his car, you know what I'm saying? Like, he's sitting up. So it was probably easier for him to breathe. And then once you put him in a bed or flat, then it's very difficult for him to do that. I'm guessing the head of his bed was up, or that was one of the interventions you guys did would be to position him.
Yeah, the head of his bed was risen, and I would notice he would fall asleep and he'd snore a couple of times, but as soon as his head started to move to the left, it tended to move to the left when he would fall asleep. As soon as it started to rotate to the side, that's where the apnea would happen.
Oh, okay. So there's some kind of blockage probably at on that side, or that's where that's happening.
That's what it looks like.
And then chest PT is something like you can, physical therapy can do that. It loosens up secretions so that you can expectorate them. And then postural drainage, you can position people certain ways so that whatever the affected lung is, things can drain out, and you can change the positions. Oxygen, you said the patient was on oxygen. You said, what did you tell me? You said mask first. And I kind of chuckled at that because I figured, was that Greg, yours was the mask and then went to the nasal cannula, because sometimes the mask just isn't enough. And with the nasal cannula, the other thing you get is a little bit of positive pressure to help keep the alveoli open. You can suction, intubating, chest tube, that's all like way beyond our scope today, but those are things that you can do to help with and or diagnose things that if there's an infection and when there's issues with gas exchange. And so again, today we're going to focus on pneumonia as our exemplar. We did touch a little bit on COPD, so that was nice. And then asthma, I think we cover that second semester. We'll go into that, but I will talk a little bit about it because I think there's some key points for asthma that you should know. What meds are you doing in pharm? I know you guys did the perfusion meds last week, right? And so what were you, were you doing pain meds or like bronchodilators and such this week? I forgot to look.
We talked about a lot of different types of inhalers.
Ah, okay. So that would have to do with asthma. That's not going to help pneumonia. Well, okay, so I will remember to talk about that when we get there. So when you talk about pneumonia, and we're going to look at the exemplar of community-acquired pneumonia, there is hospital-acquired pneumonia, but it is out there in the community. And so what happens is, if you think, I think I have a picture here in a couple slides, you get excess fluid because of inflammation due to an infection or a virus. So that inflammation gets triggered, and then there's no room for that gas exchange to happen at the alveolar level. So for example, here's an x-ray, right? Assessment, noticing, You're going to do your assessments and lab assessments. This is an x-ray here. So this is where the pneumonia is, where there's fluid in the alveoli. So the alveoli are supposed to have air in them to exchange, right? To perfuse and exchange and take in the oxygen, get rid of the carbon dioxide. But now that there's fluid in there, the air can't move, that exchange can't happen. And so you don't necessarily, you don't hear the air movement. And then there's other issues that come with that as well. Which lobe is the pneumonia in on this x-ray?
Is that right?
Right mid.
Yes, right middle, right? Because you have 3 lobes on the right side. So that's right middle lobe. Mm-hmm. And you don't have to learn how to read x-rays. I just wanted to know you knew that there was 3 lobes on the right side. And then trying to interpret, right? Are you looking for, there's decreased gas exchange. So what are you going to expect to see? Maybe there's an airway obstruction. They could get an infection, sepsis. What's the pi? What's empyema? Usually if it's a PY, it's pus. So what you end up with the fluid in the alveoli, it's kind of like fluid, but if it gets like really infected, then you've got pus. And then pus is even more difficult to get gas exchange through and looks really gross too. They did a thoracentesis on my mother-in-law and pulled off 1.5 liters of fluid out of her lung. I couldn't believe it. You just continued to watch the fluid come out, but boy, could she breathe better after they did that. It was amazing to watch. Gross, but amazing to watch her respiratory, the ease of her respiration. Like it was so much easier. And so you want to improve the gas exchange. How do you do that? You can do oxygen, right? Give them oxygen. What will incentive spirometry do for them? Have you guys had to teach anybody or seen incentive spirometry yet? Maybe somebody besides Hugo and Amanda, although I love your contributions.
It helps expand their lungs and prevents atelectasis.
And prevents atelectasis, exactly. And so just because maybe they're not post-op doesn't mean we can't give them incentive spirometer to do that, to expand the lungs, exactly. And then we want to prevent, manage all those things, positioning, do all that. And so when you're the care coordination, home care management, right? Make sure they know about the self-management, adherence to what you're telling them. But then, like, what do you do with the person that's homeless, right? And so I don't know if they were talking about discharge planning or where they were going to place the patient. And I'm not sure how a homeless person can control diabetes, right? Or do self-management. What resources do they have? You can come to the clinics and get immunizations, but based on your diet and the cleanliness or it's sort of a really sad situation. But you can have, they can do outpatient clinic visits, things like that. So you want to make sure that it doesn't just end at the hospital, right? It keeps going when they get home. And so what I want to do now is I think I'm going to put you in breakout groups. Yeah, because I want you guys to look at the case study. Hold on one second. Let me go through case study because you guys have access to this PowerPoint in the lesson, right? So you guys could pull it up in your groups. I want to read through it all together, and then I want you guys to kind of work through it. Okay. So you have an 83-year-old patient brought to the emergency department reporting a productive cough. So what's a productive cough?
There's mucus involved.
There's mucus, right? Yeah. Mucus, yes. And so what do I want to know about the mucus?
Color, odor, consistency.
Coca, right? And also I'd want to know is it the same throughout the day or just in the morning, or when is the cough occurring? Good. So she appears flushed. So that means she's kind of a little reddened, very short of breath when answering questions. She has a history of type 2 diabetes and hypertension. She doesn't have any allergies, so that's good. So they order the chest x-ray, the CBC, a basic metabolic panel, which is your sodium, potassium, BUN, which is the blood urea nitrogen. Excuse me, that all gets taken care of. They put a saline lock into the right forearm. So she doesn't have fluids running, but she has access in case they want to run some fluids. And she's admitted to the medical surgical unit with a diagnosis of suspected pneumonia. And so then what you guys can do in your groups is it keeps giving you some data here, and then it's going to ask you some questions. And then after you get through the questions and kind of check out, you know, like what is cefazolin? I know it's an antibiotic. I know we're not there yet, but you know, look up cefazolin. And then 2 hours later, it's, you know, keeps going. And now she has a weak cough, crackles now, and she's got a O2 sat of 90%. So what things would be implemented? And then there's about 3 multiple choice questions that follow the case study. So talk amongst yourselves and come up with your best answer. The most common symptom, you know, looking at what does the nurse suspect, and then the pneumonia vaccine. So you might have to look up either in the book or go to the CDC website for vaccines to look up that information. Right, so you guys are I'm gonna break you into some groups. You're gonna talk about the case study, talk through those things. If you don't know information, you're gonna look it up. And then there's about 3 questions that you guys are gonna answer. And I'm figuring maybe 15 minutes, like till 9ish, right? And then we can come back and I can walk you through how to answer the questions and all that. Does that sound fun and exciting for a Friday? Yay. No, okay. Does everybody understand what we're doing? Yes, maybe?
Yes.
Yes, okay, thank you. And then how many people do you want in your, not 10, how many people do you want in your groups? Like, do you want like 8 or like 4? 6 to 7, 5 to 6?
6 works good.
Let's do 5 to 6. Okay, there you go, manually creating. And then I'll try and pop in to some of your groups and have fun. And there they go. Bye. Oops, did you get kicked out of your group? Oh, there you go. Okay. Poof. Amy, on.
I guess I'll hang out here with you.
Okay. It sounded like the groups were having some good discussions, so I'm happy about that.
I wasn't done.
I'm sorry.
I know, it's okay.
It's all right. Always more opportunities.
It's not that I don't enjoy your company.
Thank you. I appreciate that.
D&D.
Ms. Soldier?
Yes, sir, Marco.
Quick question for you with the pneumonia vaccines.
Uh-huh.
So Is the guideline still you get both the Prevnar and the Pneumovax 23, or are they kind of moving away towards just one or the other? We're trying to figure out question 3, I believe.
Mm-hmm.
Is it still like you get Pneumovax? If you get Pneumovax first, you wait about a year and then you get Prevnar 13, or if you get Prevnar 13 first, you wait, I think 6 months to a year, and then you can get Pneumovax.
Hold on, let me look.
We were at the COVID clinic yesterday, and the director of VNA came out and was talking to us about a lot of the different vaccines that they offer, and she told us that they were no longer doing the 2.
They're not doing, okay.
Which one she said, but then I know Amanda said at her clinic they are still doing the 2, so I just wasn't sure, like, is it a
interesting
thing that's like starting to roll out? Is it CDC guidelines, like kind of where that's all coming from?
Well, that's what I'm going to look up the I'm trying to look at the we want older than 50 years, right? Because it was 72. So I was trying to look at the the CDC site to see what their recommendations are. Because it could be if it's like if they have a weakened immune system that they get both. That could be. So the polysaccharide, the 23, right? Okay, here it is. Adults 65 years or older who have never received the PCV 13, the conjugate, and do not have a condition like another health problem, may also discuss vaccinating with their provider if they want to get that or not. So I guess it depends on, again, it's a decision with your provider. And I think it must depend on if you have pre-existing conditions, things like that. I'm not going to ask you that question. So, because the focus isn't really vaccines. It was more to figure out kind of how to maybe answer the question. But I don't even see anything clearly on CDC, but I know the question comes from the reading because that's what they were saying. And it sounds like it varies, right? One facility does it one way and one facility does it another way. Always check, even whatever we teach you, check with your facility to see what their protocol is. All right, so for the case study, right, which vital sign or test result requires immediate attention?
Respiratory rate.
Is that what people came up with? Respiratory? I'm trying to get to my data.
Yeah, respiratory.
Yes.
Yes, respiratory rate. So the blood sugar is pretty high. Do we care about that? Blood pressure looks okay. I know
the
that
blood
temperature.
sugar. Yeah, the blood sugar is high, but if they can't breathe, then there's no point in lowering it.
And that is looking at the question in terms of ABCs, right? Right. And so that's why B, the respiratory rate, is the correct answer. Oops. Let's see. Airway, breathing, circulation. Yep. Okay. Next one. Oops. There we go. So you get some orders from the physician, and which order should the nurse implement first?
The oxygen.
Oxygen.
And that's airway breathing again, right? Oxygen, exactly. And if you're going to start the ANSAF, the antibiotic, are you going to start it and then do the blood cultures, or would you do blood cultures and then start the antibiotic?
Cultures first.
Mm-hmm.
Always do cultures first. Always, always, always. Cultures, any kind of collection cultures, always first before you start any antibiotics. Nice. Okay, so now they have a weak cough, crackles in the lower lobes, their SAT readings 90%, and they're on the 2 liters of oxygen. What are some things that that you could do?
So we were talking about getting an order for like a bronchodilator, right? Open them up,
Mm-hmm.
oxygen, and depending on what position that they're in, setting them up or kind of helping with?
Also, we were thinking like, sit them up and like, also maybe getting like a specimen container to have them spit some, like cough up something.
And what? How are you? How are you
color and odor?
Excuse me. And how are you going to potentially get them to cough something up?
By raising the head of the bed or having them sit on a chair.
Encourage deep coughs. Oh, the spirometer. There you go. Somebody knows where the question is in the book. Okay. The use of spirometry, high Fowlers, right? Get them up high. The incentive spirometer is going to help open up, do the gas exchange, deep cough. You can do chest percussion is what I was thinking. So we talked about that. It was on one of those earlier slides. And so that will help with the, to get the secretions loosened up a little bit, or the postural drainage.
Would you also do a nebulizer treatment with a bronchodilator?
Well, so here's the thing is they don't have asthma. So, I mean, potentially you could do like like racemic epi, or you could do that, but really it's lower airway. It's not necessarily needs to be bronchodilated. There's fluid in the lungs. But if we didn't know they had pneumonia yet, we might do that. Okay, most common symptom of pneumonia in the older adult patient.
Confusion.
What condition does the nurse suspect?
Bacterial rhinosinusitis.
Yep, the rhinosinusitis. So with this question, this again was from the book, but oh yeah, pneumonia, because we're talking about pneumonia. It's got to be pneumonia. No, read through all your choices, right? You read through it, you're going ears, sore throat, nasal congestion. Okay. I don't know what any of those things are. Okay, wait, no, I do. I know pneumonia is fluid in the lungs. That's not what that is. What the heck is a peritonsillar abscess? Has something to do with tonsils, probably. I know an abscess is not good. So that could be a potential answer. What about tuberculosis exposure? Oh yeah, tuberculosis. I know what that is. It doesn't really say anything about tuberculosis. Bacterial rhinosinusitis. What the heck is that? Okay, sinusitis, I know that has to do with sinuses, right? I'm kind of walking you through a thought process here, right? So if I can eliminate A and C, it leaves me with B and D, and I go back and look at the fever, right? And ear pressure, the sore throat, right? And the poor response to decongestants, and you would go with D as the bacterial rhinosinusitis for the answer. Okay. So we're not sure even if the question is relevant anymore, depending on what the evidence says. But what are you looking for? What's correct or what's incorrect?
What's incorrect?
What's incorrect, right? Which teaching by the nursing student requires intervention by their nurse. And so what did you come up with?
I said A, C, and D.
I believe that's correct, right? A, C, and D, yeah. Good, yay. Okay, so hopefully that was helpful. You guys are working well together, having good conversations about things, a couple practice questions in there, so that's good. So you need to be able to know the definitions for gas exchange and infection, the risk factors, things that we talked about on the slide, the compromised gas exchange, know about cough, the cough, sputum, signs and symptoms of respiratory distress, which we're going to go over in a second. And then, hand hygiene, number one for infection, right? Elevate the head of the bed, use the oxygen, those types of things for the interventions. Yes, perhaps, makes sense.
Ms. Sullinger, can
Yes,
I ask
sir.
a question about I know with COVID, they've said that a lot of patients will have these crazy low oxygen saturation rates. And that sometimes they would even put them in prone positions to open up the lungs. I don't know if you've had a chance to be in the hospital, like while patients have been treating with COVID. Have you seen anything like that? Or?
So I usually am in the pediatric population, so I haven't actually been with COVID patients. I do know that in infants, neonates, we do prone them because it helps with their breathing, because the gravity's holding them back and it's hard to get the lungs to expand. Whereas if you prone them into a more dependent position, it's a little bit easier for them to breathe. We raise the head of the bed a little bit and prone them. So I think with COVID, people were really kind of like trying to figure out whatever works. And the way I read COVID is it's different for each, like it's very individualized, what's going to help one person or the other. But it does sort of take gravity out of the equation, especially if there's a lot of fluid in the lungs. It can also potentially help with drainage. You could do postural drainage because you can Trendelenburg them. You can put the head down as well to help get rid of secretions. I don't know if that answers your question or.
Ms. Solinger, can I add something? Oh, sorry, Greg.
I'm sorry. No, Greg, go ahead.
All I was saying is I don't know if it was really a question or not. I just thought it was interesting.
Yeah.
To hear.
Mm-hmm. Okay. Who else had a question or comment?
Ms. Solinger, I can kind of add something to that. So I work at Natividad and I monitor the COVID patients as well on the telemetry and oxygen.
Yeah.
And a lot of times the doctor, he's okay with 88 and above for the COVID patients. And I know a lot of them do get prone, but it's not every patient gets prone, and it is case by case basis if it will help them. And I also know that sometimes if the ICU patients will get put on the roto bed. That one as well. I've seen that as well.
And that does the postural drainage on its own. Like it's a bed that actually lets you, right? It puts you in different positions, I believe. Yeah, that's good to know. Thank you, John.
No, you're welcome.
So we're gonna move on to upper and lower airway type things and get with gas exchange and kind of look at the different causes and what it looks like when there's issues in the upper and lower respiratory tract. And so just so we have a common definition here. Upper is like the larynx, pharynx, nose. It's like the neck up. And then lower respiratory tract would be the trachea, the bronchi, and then even down into the alveoli, alveolar duct. These are the alveoli, right? This is where the gas exchange. See the little those are little capillaries there, exchange doing the gas exchange, bringing in oxygen, taking out carbon dioxide. And so you can have different manifestations. I put this in here just so you guys kind of had a baseline of what different respiratory rates were based on age. Respiratory rate, how did they tell you to count for a full minute or just the 30 seconds or 10 seconds, or what do you do for a focused respiratory?
Full minute for an apical heart rate.
Right, this is respiratory rate.
If the breathing is even, or if it's even, then we count for 30 seconds. If we see that it's kind of irregular, then we count for a full minute.
Right, because respiratory rate can change. Whoa, that is not what I wanted to do. What was that? Yeah, because respiratory rate can change, quickly. So it's good to yeah, if it seems really even unlabored, you could probably do 30 seconds. Irregular, definitely for a minute. Whoops, I don't know why it's doing that. So this is comparing differences, which you probably could guess in the airway. Newborn, smaller than the adult, the diameter. And then when you have swelling, look what happens. There's like so much less room for gas exchange, right? So that's why any little thing like that, mucus, whatever, is gonna cause problems. More so for a pediatric patient than an adult patient. And then this just gives you a visual of some differences between an adult's upper airway and a child's upper airway. And what's one of the big things that you notice in the differences?
The length?
Because the adult, we have more room, right? And a child, things are kind of shrunk a little, you know, they're closer together. So if you get bacteria in the ear, like it's right there, right? It's just going to go right into the sinuses. And so, you know, it's smaller area, more potentially be more infection.
Right now,
Remember to mute, guys, please. Thank you. So this slide is one that you should know because this one answers one of the objectives. It's looking at respiratory distress, upper airway versus lower airway, right? So upper airway, and we'll look a little bit at retractions. Upper airway is usually some kind of obstruction, right? You've swallowed something and there's an obstruction, there's swelling, there's mucus, something is obstructing. And then lower airway, you have the same thing, but it's not, you still have an airway, right? Because it's lower disease. So you see a little bit of different symptoms with that. And we'll look at a couple examples. So this one tells you, again, upper airway obstruction. So it could be an aspiration, it could be swelling. It could be, you know, there could be a tumor. There's that peritonsillar abscess, right? Because the tonsils are back there. So if you get an abscess, on there, there's swelling, things can get blocked. You can also have congenital anomalies that make the airway different. Pneumonia should be on here. I don't know why it's not. But lower airway obstruction would be asthma because that's the bronchioles, bronchiolitis, and inflammation. We see what season is coming up for kids. Anybody know besides flu for babies?
Is it croup?
Not croup. That is an upper airway.
RSV?
RSV. Yes, RSV. Good. And RSV, tons of secretions. And it's really difficult to watch some of these kids breathe with RSV. And it is a bronchiolitis. And then the nasal flaring and the wheezing. You're going to hear wheezing. And then, so what is respiratory? Whoa, I don't know why it's doing that. I am so sorry. Let's go back here. So respiratory distress. So retractions, right? Do you know retractions? It gets sucked in, right? There's different types of retractions. So this slide shows you where potentially, usually we see intercostal or substernal. Suprasternal is not a good thing, nor is supraclavicular. These ones are not good, but these ones are really bad, just so you know. And so when you're doing your assessment, I apologize, I must have timing on or something. For babies in respiratory distress, it looks a little different. It's more use of accessory muscles, but a lot of nasal flaring and grunting. Grunting is a big sign of distress. Oops, wrong way. There we go, go back. Color, right? That's like cyanosis. There's circumoral cyanosis. There's kind of that bluish pallor there to the lips. There's some retractions, subcostal, substernal, intracostal. And you also might see mottling. You know what mottling looks like because it's not, the tissue's not being perfused appropriately. And central cyanosis, that's a late sign. We don't want cyanosis. Cyanosis is not a good thing. And then also here's your altered level of consciousness, right? And especially with the elderly, because there's not enough oxygen getting to the brain tissue. And then here's a little summary that talks about it. You might see increased respiratory rate. Restlessness, confusion is really a big thing. And then your O2 sat levels, right? We kind of want everything above 92%, would be nice. As things get worse, it starts to decrease. A normal O2 sat in a child, greater than 94. Do we want O2 sats at 100%? Do we want O2 sats at 100%?
If we can. Yeah.
I mean, yeah, and that would be nice. 98 to 100 would be in a perfect world. If a patient is on oxygen, Do we want them at 100%?
No.
No.
What would we like them at and why not?
I think, do we want them between 96 to 98? And that's because we want their brain to know that it has to keep working on its own and not just depend on the oxygen.
Because what happens if you have too much oxygen? We don't want too much. There's got to be that balance. Right. You want it needs to work on its own. I like that. I like that explanation. That works. And so the cough, the thing that you need to know, it's a symptom of both upper and lower. And so you want to assess. And also, is it a barking cough? You want to look at the secretions. If there's secretions, does it happen during the day, at night, right? All those things. And so these are, I see, this is another, I know why, because it's a different PowerPoint. So apnea, and we talked about, because you guys can read the slides, we talked about obstructive apnea. So here it is, right? That's what you guys talked about. So breathing disruption during sleep. Excessive, look at that, your excessive daytime sleepiness, right? Perfect, not perfect, but perfect. So here is CPAP, a continuous positive pressure airway machine. These are different ways that you can, a nasal pillow, they call it. There's kind of like a cannula thing, there's a mask. And then somebody mentioned BiPAP as well. And so CPAP is a continuous air pressure. It keeps the alveoli open, and it doesn't matter if you're breathing in or out, there's always this constant pressure going into your airway. With BiPAP, it's a different level for inhalation and exhalation. You can actually set it to cycle how much pressure for inhalation and exhalation. And then again, you guys can, I want to get to a couple questions at the end, but there's, I don't need you to know that what each thing is, like you have to know strep throat, blah, 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 blah. These are just examples of what an upper airway, upper airway problems would look like. You're going to have hoarseness. There's going to, like, think nose, right? Hoarseness, congestion, the throat, what's going to happen there versus if it's something in the actual lungs. I'll go back and fix the PowerPoint. I know why it's doing that. So this is strep throat. What is this thing in the middle?
Uvula.
That's your uvula. And what are these?
The tonsils.
Those are your tonsils, and those are pretty swollen because back here, that's your airway. And so think if you have with the strep, but think if you got an abscess to where there's like extra, fluid infection, that's really going to block your airway potentially, right? So that's pretty dangerous. Croup syndromes, that was the barking cough that you were talking about. So the there's the upper airway, there's the trachea there, the larynx, right? So anything that's going to cause swelling is going to cause that, either a barking cough or some kind of hoarseness. The epiglottitis, this is a medical emergency. So swelling above the vocal cords. And this is why we were talking about the HIB, right? The Haemophilus influenza B. That's why you get that, that vaccine to prevent, hopefully, epiglottitis. And I should have, yep. So this child will present, this is generally in children, but they're going to have that tripod position where they have to lean forward. There's going to be drooling, a lot of restlessness because they can't catch their breath. They're going to be really, really scared, right? And so you want to have like a tray in case they have to get into the airway, and you don't look at the throat. If they're doing that tripod positioning with the drooling, there should be my 4Ds. There's my 4Ds. If they have the 4Ds, like, don't look in the mouth. Don't, because you could, they could spasm. So drooling, difficulty swallowing, they're really distressed, and they have this like croaking sound. So if it's a croup, it's that sort of seal-like barking cough. If it's epiglottitis, it's more of like a croaking, like they can't move air through. So there is a difference there. Let me keep going here. And then lower airway exemplars, asthma, right? So there's bronchoconstriction, inflammation. That's when you use you said that you were talking about the inhalers, right? And so you have a rescue inhaler to help open up the airways, and you have your long-term, right? Different types of inhalers to systemically keep the airways open or from becoming inflamed. And that's a picture. So this is normal. And then this is, look at all that, the constriction. Like, how can you even move air through there? It's very difficult. And then chronic bronchitis. So this would be more of in an adult. So again, inflammation, thick mucus. Cystic fibrosis is another one that we tend to put in under respiratory because of the secretions, but it also, it's chloride transport. And so it also affects all these other systems. So let's do, in our last like 4 minutes, let's do a couple practice questions. So the nurse recognizes patient with sleep apnea may benefit from which interventions? Select all that apply. So what do you think about weight loss? Will that help?
Yes. Yes.
Yes, A, B, C. Okay, so, and BiPAP, will that help with sleep apnea?
Yes.
Yes. How about a change in sleeping position?
Good.
Yep.
Yep. And then medication to increase, somebody needs to mute, please. Medication to increase daytime sleepiness.
No.
No, we don't need medication to increase our sleepiness. That kind of is counterintuitive there. And I have no idea what a position fixing device that prevents tongue subluxation is, except I know that it's telling me that it's helping the tongue somehow stay in place.
Yeah, my dad has one. It grabs your chin and it pushes it forward so that when you're sleeping at night, by pulling the chin forward, it pulls the tongue and the whole back part of the throat forward to prevent that apnea from happening when you snore.
Right. So yeah, I can't even imagine having to wear that. But if I'm looking at the question and I'm not quite sure what E means, if you can kind of look through some of the words, it can give you a clue that probably would help. So A, B, C, and E are the correct answers for that one. See, you guys are getting this. Okay, so do we know about COPD? Patient with COPD presents for follow-up. They smoke 1 pack per day. PPD is pack per day. Which statement by the patient causes the nurse to suspect an increase in dyspnea? Oh my gosh, I don't know what COPD is. I don't know. Do you know what dyspnea is?
Difficulty breathing.
Difficulty breathing. So the pnea has to do with breathing, and the dys would be difficulty. So that's really all I need to know. So what statement by the patient leads the nurse to think that they have the patient has difficulty breathing?
Would it be D?
I think A, because they have to prop themselves up to breathe better.
Yeah, I would say A because it's a new thing too. They bought a new pillow and it's helping. And the question says an increase in dyspnea.
Yay, Greg. Nice thought process. Does that make sense? A. Because the weight doesn't really mean anything, and the productive cough could, but again, those don't really have anything to do with difficulty breathing, but so that you can prop yourself up. Now, the patient is well groomed and sitting in a tripod position. That's just presenting that one snapshot. That's why that's not the best answer. All right, I think we have one or two more. History of asthma. Oh, so we didn't really go over asthma, but they're having shortness of breath. We all know asthma, right? The peak flow meter indicates a peak expiratory flow reading that's in the red zone. Not quite sure what a peak flow meter is, but I'm pretty sure it has to do with the breathing flow, and it's in the red zone. Is red good or bad?
Bad.
Bad. So even if I'm not sure what asthma is or what a peak flow meter is, I mean, everybody, there's shortness of breath and something's in the red zone. So what is the priority nursing action?
Rescue drugs.
Rescue drugs, airway, rescue drugs to open the airway. You all are going, why can't you ask us questions like this on the exam? Okay, so that's a wrap for that. So we did all that. No, obstruction versus like secretions, basic nursing interventions, which we went over. Kind of be able to identify if it's a lower or upper, and then signs and symptoms of respiratory distress in different ages. So like the grunting versus the confusion, and then also know the types of retractions that you can have. That you could assess in a patient. And what else? And then one of the things that we were, yeah, I know, can these be our exam questions? Maybe. What was I thinking? If you want to make yourself a chart, we were going to do, we were going to maybe do that in class today, but I think that one slide really speaks to, those couple slides speak to, the upper versus lower airway, when you're looking at that. So you could use that as your study sheet. You don't have to like turn a comparison chart in, but if you want to do one just to have it to study, I think that'd be great. And that, I believe, will do it. Hopefully the case study and the questions helped a little bit, maybe. Hopefully. Otherwise, I will see you at 10 and we'll talk about development. Yay, good job, guys. You guys are getting it. It's happening. I can see the process.
Thank you.
You're welcome. Thank you. Thank you. Thank you. Thank you. Let me stop recording. Yep, hold on 1 second. Let me stop the recording. There we go.